Welcome everyone to the April 2023 edition of Eversight's webinar series. Today we have innovative dry eye therapies, where to turn when the standard options are not enough, with Dr. Mark Milner of Goldman Eye in Palm Beach, Florida. Everybody, all the webinar participants are going to be muted throughout the webinar, but please do ask questions. Just enter them into the Q&A panel at the bottom of your Zoom screen, or at the bottom if you're on your phone. And then please make sure to register for next month's webinar, Amniotic Membrane, the Magic Bullet, with Dr. Natalie Chung from the Department of Ophthalmology at the VA Medical Center in Cleveland. And as always, this webinar, all of our webinars are available on demand on our YouTube channel and at eversightvision.org/webinars. So I'll just briefly introduce Dr. Milner. So Dr. Milner is an associate clinical professor at the Yale University School of Medicine. He's a partner and the director of cornea at Goldman Eye in Palm Beach Gardens, Florida. He was co-medical director of Precision LASIK Group. Dr. Milner did his residency at New York Eye and Ear and his fellowship at Francis Proctor Foundation in Cornea, External Diseases and Uveitis in San Francisco, California. In 2016, Dr. Milner was selected on the list of Ocular Surgery News Premier Surgeon 300 as one of the top 300 premier surgeons and leading innovators in the US. And in 2022, he was on Newsweek's list of America's top eye doctors. Dr. Milner has lectured all over the world in cornea and in dry eye and is on several advisory boards. He's been involved in several phase 2 and 3 clinical studies and has developed his own algorithm on dry eye, which is published in Current Opinion in Ophthalmology in January 2017 and is currently available online. And so, Dr. Milner, I will turn the floor over to you.
Thank you, Mike. Thanks a lot. Thanks for having me. Welcome, everybody. I hope all of you had a nice day and you're excited about learning some innovative approaches for dry eye when the standard options are not enough. Actually, you could also name this talk New Options, Current and in the Pipeline to Supplement Standard Options. So in other words, when you're in your practice and you are seeing patients and you've tried all the standard treatments, what else can you do when you're scratching your head and you're like, I need more than what's commercially available? So these are my disclosures. I definitely have some of these are financial interests in some of the things I'll be talking about. I work with a lot of dry companies on several advisory boards. So if you separate treatments, some innovative and new options, they really can be broken down into 5 different categories. First is compounded meds. Second is biologics. I know Mike just said that your next webinar is going to be on amniotic membrane. We're going to talk about that today as well. Not quite as extensively as next webinar, but we'll touch upon it. 3 is neurostimulation. 4 is immunosuppression. We have some commercially available immunosuppressive agents, but we're going to talk about some newer ones. And then lastly, some new anti-infectives. So let's talk about compounded meds. To me, this is my staple of my practice. This is my go-to when I have already utilized a lot of the commercial approaches and nothing else works. I start to reach for some of my great compounded options. And the basics of compounded meds, the FDA definition is a practice in which a licensed pharmacist, a licensed physician, or in the case of an outsourcing facility, a person under the supervision of a licensed pharmacist combines, mixes, or alters ingredients of a drug to create medication tailored to the needs of an individual patient. So what are some examples of not commercially available drugs or compounded meds? Well, the first one is an off-label use of a commercially available drug, meaning albumin is used for hemodynamic status. Well, our compounding pharmacy can make topical albumin drops for dry eye disease. And I use albumin a lot for people who can't get autologous serum. Albumin works well. As we know, it's a protein, but it has a lot of mucoadhesive effects, and patients feel very comfortable using albumin drops anywhere from 1 to 4 times a day. And I'll get into that in detail in a second. What about using a different concentration of a commercially available drug? For example, we have cyclosporine drops commercially available. We have 0.05 and 0.09 and now 0.1, but we don't have 2%. And so we'll sometimes compound 2% cyclosporine. That's another example of a different concentration. What about a combination of commercially available drugs? So we all use prednisolone acetate, gadafloxacin, and ketorolac for cataract surgery. But if you combine all 3 of those into 1 drop for cataract surgery, that's an example of a compounded med. The use of a commercially available drug in a different location or form, meaning we use vancomycin for infections, but to compound it in topical form for a corneal ulcer is a compounded medicine that's used in a different location. And then lastly is reformulation of a commercially available drug. So for example, we have pilocarpine drops for glaucoma. We used to compound preservative-free pilocarpine. And so these are some of the examples of compounded meds that you can use in the eye. So what about using them for dry disease? Well, as Mike mentioned, I published my algorithm in 2017. It's the CEDARS algorithm. And as you know, a lot of algorithms out there have what's called a severity-based approach, meaning that you treat mild dry eye differently than you treat moderate or severe. Well, it never made sense to me. So what I did was I separated patients into 4 diagnostic categories. Tear deficiency, meaning a low tear volume. Goblet cell deficiency or mucin deficiency. This is a small category, but we know people get cicatricial conjunctivitis, tend to lose goblet cells and they lose mucin. We all think of evaporative tear syndrome as just being blepharitis, but if you lose goblet cells and lose mucin, you have an evaporative tear syndrome. And you may not have blepharitis, but still be evaporative. And then blepharitis is the 3rd category. It's the biggest category out there. Exposure keratopathy, people forget this. If you have a Bell's palsy or if you can't close your eye, you know, when I was in Connecticut for 25 years, I used to ask my patients if they've ever had a blepharoplasty. And now that I'm down in Palm Beach Gardens, I ask them when they've had their blepharoplasty, because almost everyone's had plastic surgery here. So we know those patients sometimes can't close their eye, and they will definitely get exposure keratopathy. So if you can separate your patients into these 4 categories, well, now you can approach them with more of a pointed diagnostic approach. So for tear deficiency, here's the list of things I use. You know about tear supplements, right? Cyclosporine, lifitegrast, steroids, plugs. Some of the innovative treatments would include autologous serum, oral secretagogues, but some of the compounded meds that I love is I love topical hormones like medroxyprogesterone or DHEA, which is a topical androgen. I've also used a lot of a 50-50 testosterone progesterone mix, and these have anti-inflammatory effects. They work great to help with the ocular surface inflammation, and all the information that you need on this is in our algorithm in Current Opinion in Ophthalmology, January 2017. If you want, you can I can get it to you. You can just go on Current Opinion Ophthalmology, Google Milner, and you can download a PDF for free. Other innovative treatments, everyone knows about omega-3s, but some other compounded meds. We talked about albumin having that mucoadhesive effect, and then dapsone as another immunosuppressive agent. For goblet cell deficiency, cyclosporine and lifitegrast work great, but if you want a compounded medicine, there's vitamin A or retinoic acid. We used to compound vitamin A. Vitamin A helps replenish goblet cells. It's a great treatment for your cicatricial patients like Stevens-Johnson or toxic epidermal necrolysis or pemphigoid, even EKC patients. There's now a commercially available form of vitamin A called Hyalonite from Optase, and that has vitamin A ointment. You can get it on Amazon. It's a great treatment for your patients with conjunctival scarring to help replenish goblet cells. And then moist chamber goggles and scleral lenses. For blepharitis, everyone knows about lid hygiene, and one of my innovative treatments, in addition to cyclosporine and lifitegrast, which have great off-label uses for blepharitis, topical Eversight is a great treatment. I use it all the time off-labelly for blepharitis. It has great tissue penetration, great coverage for the flora of the eye, and really works well to reduce the inflammation. But some of one of my favorite of all-time treatments for blepharitis, and especially posterior blepharitis, is metronidazole ointment compounded. Just like you would use Metrogel for the face for rosacea, we compound metronidazole for the eye and use it at bedtime, and it is great for your rosacea patients. It works just like Metrogel works for the face. Very well tolerated. My patients love it. And oral doxycycline, lid scrubs, other compounded meds. If you can't use oral, we compound doxy drops, which works well. And then just like Cleocin for the face, we compound topical clindamycin ointment. Or if you can't get the Eversight, it's on back order, you can do topical azithromycin as well as a compounded med. So these are some of the compounded meds that I use in my algorithm. They're really a great option. They're all safe for when you have a situation where nothing's working, you can think of those. And then in the pipeline, Richard G is looking at spironolactone as a compounded med. That's coming down the road for both aqueous deficiency and meibomian gland disease, and really it looks promising. I've gotten some samples of that, and I feel like patients do well with that too. Okay, the second category is biologics, and like Mike said, you're going to have a lecture next, a webinar on amniotic membrane. I'm going to touch upon it quickly, but there are 2 biologics that we talk about with dry eye: amniotic membrane and cytokine extract drops. The amniotic membrane is separated into cryopreserved and dehydrated. There's actually lyophilized, which is another type. It's somewhere in between. I'll tell you a little bit about the difference between cryopreserved and dehydrated. And then the cytokine extract drops from amniotic membrane we'll go through in a little bit. So amniotic membrane, what makes amniotic membrane work? Well, the key component that's thought to be responsible is this complex, which I call the fetal complex. It's actually heavy chain, hyaluronic acid, and pentraxin 3. When you hear that, you think, what is this mumbling that he's saying? Well, heavy chain, we know, are components of immune globulins. Hyaluronic acid and pentraxin 3 are two components that we see in inflammatory cascades. All three of these things are found in the adult, but they're only found together in the fetus and in the placenta or the amniotic membrane. And actually, Sheffer-Seng did a lot of work with this. And the thought is that this complex, this heavy chain hyaluronic acid and pentraxin 3, this complex together, it's what's thought to provide what's called regenerative healing. So let's take a step back. What is regenerative healing? Well, if you, in an adult, when you injure yourself, the goal of the body is to help prevent any damage from the environment and to repair. So for example, if I were to take out a neck mass, I'd have a scar on my neck. But in the fetus, the goal is to basically follow genetic plan, get back to its original form. So if you actually, and there are great pictures of this, if you take a fetus out of utero and take out a neck mass and then put it back in utero, they're born without a scar because that genetic plan, this fetal complex, helps regenerate tissue. So Sheffer-Seng did work showing that if you have this fetal complex together, it does things like suppress inflammation, anti-scarring, and promotes regenerative healing. How does it do that? Well, suppressing inflammation by facilitating neutrophil apoptosis, by polarizing M1 to M2. M2s are mostly healing macrophages, and it suppresses T helper cells such as 1 and 17. Anti-scarring is preventing myofibroblast differentiation, and so it helps prevent that scar formation, then promoting regenerative healing by really supporting that mesenchymal cell and maintaining that stem cell quiescence, that quiet surface. So with the difference between dehydrated and cryopreserved, and this is one thing that, granted, it comes from biotissue, which is Sheffer-Seng's, but Cook did a study showing that if you believe that this fetal complex is really critical, then one of the things that you will see in these assays is that the cryopreserved maintains the heavy molecular weight hyaluronic acid, which is the anti-inflammatory. It maintains the heavy chain and pentraxin 3, but in the dry, they're lost. You lose all these components in the assays. And so the theory being is that if you can keep it in like a Procara, then you'll maintain this fetal complex, and in dry, you might lose these complexes. And that's why the FDA allowed Procara and biotissue and amniograft, the cryopreserved, to be able to say that they have anti-angiogenesis, anti-scarring, and anti-inflammation, but the FDA did not permit the cryopreserved to say that. They were only allowed to say that they have wound covering. So that, and the reason they did that was because of these studies. So there were two big studies that came out for looking at amniotic membrane with dry disease. It was Thomas John's corneal nerve regeneration, cryopreserved amniotic membrane in dry disease. And if you look at this, let's see if I can move here. Let me go back for a second. He looked at, it was a prospective controlled study looking at patients with moderate to severe dry disease, DEWS level 2 to 4, 20 patients, and they were randomized to either receive a self-retained amniotic membrane or Procara for 5 days or conventional therapy. Those are the two treatments. And then they looked at the patients at baseline, 1 month, and 3 months. And what they found was a statistically significant decrease in the signs and symptoms of dry disease for the Procara compared to the conventional therapy. So look at things like pain score and speed score for symptoms, all statistically better at 3 months than conventional therapy. Corneal staining, tear breakup time, and the DEWS score, all better. Every single category statistically better for one application of cryopreservation versus conventional therapy. But maybe the most important thing that Thomas John showed is that when you apply one Procara, you get an increase in corneal nerve density because of this regenerative healing, and an increase in corneal nerve sensitivity. And actually, this concept of regenerating nerves was also seen in Pedram-Hamra's study of amniotic membrane, application of one Procara as well. So this was reproduced. Well, Margaret McDonald did another DREAM study, not the DREAM study that you know of with the omega-3 medicines, This was more of a dream study looking at dry eye and amniotic membrane. And there were 10 clinical sites. They looked at a cryopreserved amniotic membrane in DUES scores 3 to 4, and they compared it. They didn't actually do a head-to-head. They looked at patients who actually did not do well with conventional therapy, meaning people who are on artificial tears, cyclosporine, serum tears, antibiotics, steroids. They received an amniotic membrane and then one application, and then looked at 3-month follow-up. So these were patients who actually failed conventional therapy. And these were done in 10 sites around the country. And there were 97 eyes of 84 patients looking at moderate to severe dry eye. And they had all the components of severe dry eye with punctate keratitis in 86%, filaments in 13%, et cetera. The application was 5.4 days on average with a plus or minus 2.8 days. And there were no adverse events in this study. And again, if you look at signs and symptoms at 3 months, all statistically better for things like DUES score, ocular discomfort score, vision score, these were all symptoms, and then corneal staining and signs, all statistically better at 3 months compared to baseline. And this was for patients who really failed conventional therapy. So amniotic membrane, we definitely use it for our moderate to severe dry patients. What about if you want to use drops, like drops from amniotic membrane or cytokine drops? Well, these are like amniotic membrane drops. There's 2 companies. There's Regenerize and Stimulize right now, and they contain cytokines, the good cytokines, not the bad ones, the chemokines, and more importantly, they contain growth factors. And they also have hyaluronic acid, which isn't a lot of artificial tears. A lot of newer tear companies like Ivizia are using hyaluronic acid because they have great lubrication and great mucoadhesive effects as well. And you can use them 1 to 4 times a day. What's in the pipeline? Well, BioTissue is working on umbilical cord drops, and this is going to be like amniotic drops or cytokine drops on steroids, no pun intended. These are amniotic cord drops are really high level of fetal healing and regenerative, and they're seeking a biologic license now for these. So that's coming down the road. Okay, how about neurostimulation? What's currently available? Well, varenicline solution, or we all know this as Tyrvaya, 0.03 milligrams. It's a nicotinic acetylcholine receptor agonist, and it's from Oyster Point. Everyone knows that there used to be a neurostimulator called TruTear, which was an electrical neurostimulator from Allergan. And although that worked, the business model and people did not want to bring this to their restaurant and start sticking things up their nose when they needed it. So it never really caught on, and Allergan actually shelved it. But the way neurostimulation works is the afferents from the nose, all right, through the anterior ethmoidal nerve, traveling through the branch of the trigeminal nerve, go to the CNS, and then that's through the afferents. The efferents are sent back to it through the parasympathetic of the trigeminal nerve to what's called the lacrimal functional unit. Lacrimal functional unit means that it's innervating the meibomian glands, producing lipid, the goblet cells producing mucin, and the lacrimal gland producing aqueous. So when you stimulate that afferent, that nerve, you're getting a complete tear. Everyone thinks of it as a reflex tear. It's really not. You're getting all 3 components. And if you think about this as like, if you've gotten hit in the nose with a tennis ball, if you smelled spicy foods, you know that your eye starts to tear. And that's the way it works. Actually, a portion of our basal tears are just from the air when we inhale, stimulating that anterior ethmoidal nerve and causing a stimulation so that we make this basal tear, this complete tear with all 3 components. So varenicline solution, the nasal spray, was looked at in 3 pre-approval studies. One was a phase 2B and the other was phase 3, and then an ex-US study. Onset 1 and Onset 2 were in the US, and they were 4-week studies. The Mystic was in Mexico, and that was a 12-week study. You can see the number of patients here. The primary endpoints were all objective dry eye signs, and then secondary were signs and symptoms. So the phase 2 really looked at differences in the concentration. So they looked at 0.06 milligrams of varenicline compared to 0.03 versus 0.006 versus a vehicle. Phase 3, or the Onset 2, just narrowed it down to 0.06 and 0.03. And 0.03 is what they settled on for their Tyrvaya. And they looked at that compared to the vehicle as well. What they found was almost every study that's done that goes to the FDA looks at the percentage of patients that increase their Schirmer scores by greater than 10 from baseline. Meaning, if they started a certain mean number, what percentage of patients bumped it up by 10 or more in Schirmer's? And that's a very hard endpoint to achieve. In fact, it's so difficult that Restasis was approved at about 17% at 6 months. And you know that the other drugs were like in the range of 16 to 19%. So if you look at varenicline solution, this is at 4 weeks, they were 52% had achieved a greater than 10 millimeter bump compared to the vehicle, which was 14% in onset 1 and 47% in onset 2. But the other thing they looked at, well, what was the mean change in baseline from the baseline score? And the mean change was 11.7 compared to 3.2 for the vehicle for onset 1 and 11.3. These were both statistically significant compared to the vehicle. When they looked at eye dryness score symptoms, what's interesting is onset 1 met the symptom score, and that was both in the controlled adverse environment, that RV that they use where they really pump in hot air, lower the humidity, and they really cause a major dry eye versus just in the clinic environment. Onset 1 met the symptoms, and onset 2 wasn't quite statistically significant, but the FDA allowed Oyster Point to say that they have they're indicated for both signs and symptoms because onset 1 did meet it and onset 2 was close. But what the MYSTIC study showed, this ex-US study in Mexico, was everyone says, well, is there tachyphylaxis? So you're going to get, does this continue on? When they found at day 84, the increase in Schirmer scores were just as great compared to the vehicles they were at day 7. So this really shows that this is, and the other study, the day 7, 28, and 52 are not primary endpoints, were not pre-described endpoints, but the day 84 was, and it still was, it showed a statistically significant improvement out to roughly almost 3 months. Okay, what about new immunosuppressive agents, new and in the pipeline? So we talked about cyclosporine, Restasis is 0.05%, Cequa is 0.09%. Well, there's a new cyclosporine out. Technically, it's not for dry eye, although people are using it off-labelly. The issue is getting coverage for dry eye, and that's Verkazia. Verkazia is it's really approved for vernal keratoconjunctivitis, and it's a 4-time-a-day drop as opposed to a 2-time-a-day drop. But we know we've been using Restasis and Cequa for vernal keratoconjunctivitis for years because we know that vernal, atopic, and GPC have not just a histamine response, but also a T-cell response. So that's why if you're going to treat regular hay fever, you use antihistamines, but if you're going to treat vernal, atopic, or GPC, you want to use your favorite mast cell stabilizer to treat the mast cells and the histamines, and then you want to use your T-cell immunomodulators like Verkazia or Restasis or Cequa. But I think one of the greatest things that's going to come down the road, in my opinion, and this looks very promising, and we always say this looks great. Sometimes they work, sometimes they don't. I think this one is going to work. It's called a RASP inhibitor, and Aldera has what's called Reproxalap. And what is a RASP inhibitor? Well, this is something I was on an advisory board with cornea specialists, and they didn't even know what RASP inhibitors were. So we all had to really learn about this. RASP inhibitors are what's called reactive aldehyde species, or RASP. And Reproxalap is Aldera's drug that actually it's a first-in-class immunomodulator, and it inhibits RASPs, or those reactive aldehyde. What makes it so special is that it's pre-cytokine, so it works upstream, meaning as opposed to where the steroids and cyclosporins work downstream, this works way above the top, almost to blanket the whole inflammatory response. So because of that, it has a very rapid onset. And so you'll see improvement in the matter of days rather than weeks and months. Right now, they're looking at it for dry and allergic conjunctivitis, and it's in phase 3. Really, I think it's scheduled for a PDUFA date soon, if not already. So how does this work? Well, the RASP inhibitor is really high in this cascade, and it blocks and binds T cells and cytokines way upstream. So that by the time it gets down to the inflammation, it really has suppressed that inflammation. So look out for Reproxalap from Aldera. I think it's going to be promising for a really, without the side effects of steroids, with a good immunosuppressive agent that works a lot quicker like steroids do. Okay, let's finish up with some anti-infectives. And so we have anti-infectives in the pipeline like anti-Demodex or lotilaner from Tarsus. And we know that there are two types. Demodex is some people say it's ubiquitous, like everybody has a little bit of Demodex. It's really very common. If you start looking for what they're calling collarettes, or what I call sleeves, it's called both. If you see them in this, like in this picture here, you have them look down. Really a great way to find is to look down. You'll see these sleeves around the lashes. And that is basically the excrement of the Demodex. And there's two types of Demodex. There's follicularum, which is really found in the follicles, and the brevis, which is found in the meibomian glands. And both of these things feed on the cells of your skin, as well as some bacteria. So what lotilaner is, it's really an anti-parasite. And what it does is it works by paralysis and death of these Demodex mites. So in their studies, they identified the collarettes. They used the dosing twice a day for 6 weeks, and their endpoint was primary collarette cure. Secondary was mite eradication, and then redness and collarette cure rate. They also looked at, obviously, tolerability. And so just to highlight their conclusions of their Saturn I from Tarsus, all the primary and secondary endpoints were met with high statistical significance. And they had clinically meaningful cure seen in 81% of patients. So this is also on the launching pad to be released. And right now, all we have for Demodex is tea tree oil. So we're using a lot of tea tree oil wipes. But this looks to really be promising for all these blepharitis patients that have these chronic Demodex that really continue to haunt us when they come in because they still have symptoms. So let's end with some future medical developments, and then we'll go to some questions. Well, perfluorohexooctane by Novaliq sold it to B&L. This is Nova Tears, and they're actually doing not just a tear, but a tear and cyclosporine. This really looks amazing to me. The Novaliq or the Nova Tears itself have some great improvement in signs and symptoms without anything added, and now they're talking about using it in combination with cyclosporine to have a really good combination drug. There's bandage gels to help with healing. iGate Pharma is looking at that. And then there's other formulations of cyclosporine. We talked about Aldira. There's the spleen tyrosine kinase inhibitors, other selective glucocorticoid receptor antagonists. There's nuclear factor kappa beta inhibitors. There's some capsaicin for the eye. So there's some stuff not just for inflammation, but pain, neuromodulators such as naltrexone, which is an opioid antagonist. And then there's other reparative medicines like collagen mimetic proteins to help with healing, lubricin, and then some other neurosecretory. They're looking at other oral secretagogues as well. We talked about lotilaner, and then there's other companies that are really early. The technology is confidential for anti-Demodex and things like meibomian gland disease. So in summary, we have a lot of things in the pipeline. You have a lot of compounded meds now. You can look at things where if you say, you know what, I've been treating this patient with all the commercially available options, things are just not working. Start thinking about these out-of-the-box options, and you really help your patients. And remember, dry eye is a complex disease. No one treatment is a panacea. I think the mistake that a lot of doctors make is they'll put them on cyclosporine or lifitegrast. The patient will get 30% better. And the doctor will say, okay, well, that's not enough. Let's switch it. Well, remember, dry eye like glaucoma is often a multi-treatment disease. If you had a glaucoma patient that was on a drop that dropped the pressure from 27 to 22, you wouldn't say it failed. You'd add another treatment. It's the same thing with dry eye. If you add a treatment like cyclosporine or lifitegrast and they're not 100%, and they still have meibomian gland disease, think about metronidazole ointment as a compounded medicine for their posterior blepharitis. Patient responses and adverse reactions differ for different therapies. So whereas one patient may love cyclosporine and another patient may love lifitegrast, everyone's different. So feel free to try some of these different medicines. Don't fall in love with one medicine. I actually use all three. I use Restasis, Xiidra, and Cequa because I think that they're all excellent treatments and patients get different responses. And then a partial improvement is not a failure. Like I said, if you get 30% improvement, great, now add to it. And finally, the future is very bright. We have a lot of things in our armament and our toolbox and more things coming down the road. So with that, thank you for taking your early evening to listen to this webinar, and I'm open for any questions now at this time.
Thanks so much, Dr. Milner. I had a little bit of time there to contemplate how I'm going to look for tiny mites in my own eyelashes.
I know.
I don't know if
It
I'll be
is
able
kind
to
of
figure that.
I will tell you, that if you ever saw a video that Tarsus shows of the mites crawling into and out of your glands, it is the stuff that nightmares are made of. Like, I don't know how they're going to show patients that, because we're going to be getting calls daily from people who are panicked about it.
Yeah, I just need to be behind the slit lamp for a moment, if you could take a look.
Yeah.
So I have a couple questions here for you. So the first one is, when you use dapsone, is it as topical or oral?
Yeah, that's a great question. These are all topical. Everything that I told, that's the beauty about these compounded medicines. With the exception of some oral secretagogues, everything in my algorithm is topical, so it's safe. There's really no systemic absorption. And so the dapsone is compound. Now, just for, we did the CEDAS algorithm. The one who uses dapsone a lot is our second author. I was the primary author. It was Ken Beckman. He's the one that always said he used dapsone a lot. So if you have any information about using dapsone as we use dapsone orally for pemphigoid, but topically he uses it for dry eyes. So, and in our algorithm, it talks about the how to go about doing that. But yeah, it's a topical, not an oral.
Thank you. And do you want to you had that slide that kind of showed your whole algorithm in a consent format, right?
Yeah. So if you want the algorithm, it is, I'm trying to look at it now. So it's current opinion in ophthalmology, January 2017. And what you can do is you can, if you go to current opinion in ophthalmology and you basically just Google my name, it should come up and you can just download the PDF, and it's free, like I said. And then in the algorithm here, I don't know if you can see, probably can't see it, it's blurred out, but in the algorithm, it has the different categories and all the esoteric treatments. And then if you go through the text, it talks about each treatment. And I know someone asked about the percentage of dapsone, and I'm looking at it now because I don't use it as often. So it says here that dapsone is used 5% gel, although dapsone is considered anti-infective. The compounded dapsone is 0.25%, has been used for the treatment of patients with tear deficiency. So it's 0.25%. Okay.
And what I'll do is I'll get that link from you, and I'll try to put it in the YouTube.
Okay. Yeah, I can give that to you for sure.
Yeah.
The other question was,
so the next question is, do you ever have patients on both Xiidra and Restasis or Cequa? And is there any way to get discounts for these patients if they are on Medicare or Medicaid?
Right, so it's a phenomenal question, because all the dry specialists use both Xiidra and Restasis or Cequa together, because as you know, the cyclosporins work by going inside the cell, right? They're a calcineurin phosphatase inhibitor. They go into the cell to stop the T cell from activating and producing cytokines. Whereas Xiidra is an LFA1 antagonist, so it works on the outside of the cell. It actually prevents the ICAMs from attaching to the LFA1 on the T cell. The ICAMs are upregulated on the surface of your eye, so as that LFA1 sees it and attaches to it, that's what upregulates and stimulates the T cell. So they work in different parts of the T cell, which means that they are synergistic. So I use Xiidra and either Restasis or Cequa a lot together. But as you mentioned, the problem is getting it covered, and a lot of companies don't like to get them covered together. So here's a trick for you. If you can get the Xiidra covered, Cequa, if it's not covered, and you go through Unity Pharmacy, we'll do it for $89. And remember, if you stretch the vials, you get 4 months out of a Cequa 1 month kit, and you get same thing with Restasis. So you can get 4 months out of both of those, and you get 2 months out of Xiidra because there's less per vial. So what I like to do is I'll usually get it covered for Xiidra, and then I'll try to go to Unity Pharmacy and get the Cequa covered, not covered, but sent to them for $89 as a non-covered drug. You have to just show that it's not covered, and they'll do it for $89. But yeah, we use them together a lot for this more moderate to severe patients. Great question.
All right, thank you. And so we have two questions related to, of course, compounding and compounded drops, because we know access to these can be difficult.
Yeah.
And so the first question is what are the percentages of some of the medications you listed that you use, compounded medications?
Right. So for example, things like, and it's all in the article. So if you go through it, each thing is in there. And so for example, the metronidazole is 0.75. I believe that the topical hormones vary. So let's see if I can find it here very quickly. So okay, the medroxyprogesterone is 1%. The 50-50 testosterone progesterone is each 0.5%, and then the DHEA is either 0.5 or 1%. So again, I don't always remember the percentages. I have it listed, and just so that you know, I use VLS Pharmacy, and so VLS is in Brooklyn, and they make a lot of different compounded meds, and they'll ship it out to many states, and they have all the percentages. And if you have any questions, you can always contact me as well. But yeah, the percentages are in there, and we'll get that link to you for the algorithm.
Yeah, and you just spoke to it a little bit, mentioning your pharmacy. The next question was curious as to your protocol for obtaining some compounded drops.
So what we do is we have a form in our office that we fax to VLS. I literally probably send 3 or 4 meds a day. So they have me, they know me very well. And so all you have to do is, if you want more information about it, VLS is in Brooklyn. I'll get all that information to Mike, the pharmacy, and their number, as well as you can have local pharmacies in your cities and states that do it as well. But I know VLS does ophthalmic. I know that they really specialize in that. And I used to use what was it called out in San Diego, Chuck Leiter's, Leiter's Pharmacy. But then they sold and they stopped doing iMeds. So I started using a couple others around the country, but I've really settled in on VLS because they do everything for me now. And they'll
ship nationwide.
They'll ship nationwide. Yep. They ship to me down in Florida.
Yeah. The next question is, what has your experience been for OCP patients and vitamin A?
Yeah, so like I said, I love using, so remember, be careful about using vitamin A orally. I don't recommend using it orally, although oral vitamin A may help with things like dry eye. Vitamin A deficiency definitely causes dry eye. It can also cause, unfortunately, people to have a chronic HSV, because when we lose vitamin A, for whatever reason, our immune system that fights herpes is really diminished. So by the way, if you do have a patient that has like a chronic herpes that's not going away, or a peripheral herpes, see if they have vitamin A deficiency. Now, who gets vitamin A deficiency? Well, anybody who has had malabsorption syndrome, like people who have had gastric bypasses can get vitamin A deficiency. So I had a patient like that, and I didn't even think of it. And Todd Margolis, one of my mentors, said, yeah, are they vitamin A deficient? I thought, why would you even think of that? And then we did, and sure enough, they were. We replenished it. I always do it with the help of an internist, because vitamin A is fat soluble. So remember, if you do have a vitamin A deficiency and overdo it, you can get a hypervitaminosis, just like you can get with vitamin D. So vitamin C is water soluble, so you'll pee it out. But vitamin A, you shouldn't really do oral unless you do it with the help of somebody and check levels. Now, vitamin A, topically, you can do as much as you want. And vitamin A, like we said, Hyalonite from Optase, I love using vitamin A ointment for my cicatricial patients like pemphigoid, as well as Stevens-Johnson, because we know they're goblet cell deficient. And so I use it at bedtime. I use vitamin A ointment at bedtime, and I'm getting great success with helping with that evaporative tear syndrome. So yeah, I have good success with pemphigoid and with Stevens-Johnson and TEN, et cetera. And then yes, I guess the other question was using Unity Pharmacy. Yeah, Mike said they'll get that. Yeah, so we'll get the Unity Pharmacy, we'll get my algorithm, and as well as the VLS Pharmacy. Unity is that specialty pharmacy that does the prior auths for us for Sequa.
Great, yeah. It doesn't look like we have any questions left. Let me just check the Q&A one time. It looks like you've answered everything. So thanks a ton, Dr. Milner, for doing this talk.
My pleasure.
That's a really great topic. We know these patients struggle a lot, and there's a lot of different treatments, obviously, to talk about. Everyone, all the participants, you'll all receive a link in your email with a quick survey about today's webinar. If it's just like click, if you could take 2 seconds to fill it out, we'd appreciate it. And like we said, join us next month in May for talk about amniotic membrane with Dr. Natalie Chung from Cleveland. And that's all we have for you tonight. Any closing words, Dr. Milner?
No, thank you so much, Mike, for having me. And everyone stay safe out there. And if you have any questions, contact me. I'm always available to help. So thank you so much for attending tonight.
Thank you. And thanks to everyone who joined. And we'll see you all at the next one. Have a good night.
Good night.